Very good evening and welcome to all of you today to our OSCE session. It is our regular attendance and introduction to you, those who are appearing for the exam and preparing for the OSCE exam. And in general, we invite though or our colleagues are gathered for our structured, organized program, but just to stimulate you and to create the thought process how to prepare by yourself. This is our little participation in your journey. As before, this is my humble introduction to you. And I will come to the next now, Doctor. This is our name of the institute. I hope all of you know almost. And today, as informed earlier, you can remember our previous class of focused clinical examination. We discussed, but as the clinical examination is an mostly skill-based part of your performance, and we need to know how to perform it. And for that, we are thinking to invite you for a practice session. And today we will not discuss the focused examination, what it is and others. Today, what we will do, we will show you a recorded video of hours before. Our previous candidates performed it and they have passed. From there, I will give you to let you hear only the history part of the consultation. In the meantime, you will prepare by yourself for understanding purpose also. You will just keep in your mind what examination will be, focused examination for this history. And we will invite you one by one. I hope it will be very interesting for you and you will enjoy it today. So get ready in this manner to participate. Unfortunately, we will not allow all of you. Very few, 2-3 candidates be allowed for this purpose. So now you just get prepared and try to avoid or minimize your surrounding noise and others. So those who have the clear environment, only they can join better. Anyway, so let's move now. Before going, just to remind you the mistakes which we found and understanding by the MRCGP in the examination especially, that the candidates are not focused on the pertinent examination. The examinations are not complete and techniques are not effective. That means ineffective examination technique and overlooking the patient comfort. Another word, it is said as patient's well-being. So these are 4 major observations. That means we shouldn't do. Keeping in the mind, let's see, we studied a lot. I mean you, my colleague, beloved colleagues, and how much you have practiced, I don't know. Today, let's see, just especially focusing the focused clinical examination, not whole session, only this part. And this part really different thing in a sense that in our course also, our examination part is online. It is very virtual. It will prepare you to do the real examination in the exam hall. Interestingly, in the OSCE, there will be no real patient. So these online virtual practice session is very effective as well. Anyway, what we do, you will understand now. And I will show this video, including the voice. So can anyone raise the hand who will be joining with us in the practice? Enter, please.
Okay. Hello, Mr. Silva.
Hello, Mr. Silva.
How can I help you today?
Hello. Dr. Hin, you shouldn't say anything. You just listen until the history. Then after the history, you will tell that I'm doing this one. You can address to Mr. Silva also. That Mr. Silva, can I examine you? Then he will say, I am examining this in the general examination and the systemic examination, local examination, like that. I will guide you later. Just all of you, please listen. It will be a little newer design of class for all of you. So you try your best to be in touch with us. Doctor, good evening, doctor. Doctor, I'm having leg pain, doctor, last 2 months. Doctor, I don't know what
Please.
is wrong with me. I took some paracetamol sometime, ibuprofen also, but no relief, doctor. Please tell me what is wrong with me, doctor, please.
Okay, Mr. Silva. To know more about your, can you tell me more?
What you like to know more, doctor? You can ask me, please.
Yes, I want to know, is this pain started with you suddenly or gradually?
Over a few days, doctor, day by day, it is becoming more, doctor.
Okay, is it in your right leg or left leg?
In the right leg more, doctor, than left leg.
Okay, can you tell me how this pain is like?
Just cramping pain, doctor.
Okay, I will give you score from 1 to 10. 1 for least severe pain and 10 for most severe pain. Can you score this pain to me?
It is actually not persistent, doctor. When pain
Yeah.
become maximum, at that time it become 5 or 6, doctor.
Okay, anything make it worse?
Yeah, doctor, when I actually start to walk, and after a few minutes, then pain starts. And after a while, doctor, I need to stop my walking, doctor.
Mm-hmm. Okay, anything make it better?
Just if I stop walking, then it becomes a little better. And in the rest time, there is no pain. Right now, doctor, I don't have any pain.
Okay, is it worsening with time?
Day by day, doctor, it is becoming more problematic, doctor.
Okay, does it go anywhere?
No, doctor, it is in my the leg, doctor, only.
Okay, Mr. Silva, do you have any fever?
No, doctor.
Okay, any injury to your leg?
No injury, doctor, in the meantime.
Eh, Okay, any swelling?
I didn't find any swelling. Rather, doctor, I'm thinking that my leg become thinner than before.
Okay, can you point it to the site exactly in your leg?
Is it below the knee, doctor? In the cuff area, doctor. More pain.
Okay, Mr. Silva, do you have any long-standing illness like high blood pressure,
No, doctor.
high blood sugar?
No, doctor. Just 5 months before, doctor, my sugar was checked. They told me it was a little high, but I didn't check further, doctor, later.
Uh, can you remember the reading?
It was actually when I was walking in the road, somebody measuring, and they told me at that time my sugar was 9.8 millimole per
9.8.
liter. Yeah.
Mm-hmm. Okay, okay. Mr. Silva, do you have any chest pain?
No, doctor.
Okay. Can I ask you private question?
Yeah, doctor, please.
Any pain during your private relation?
Pain, doctor? No, no
Any
pain.
problem, I mean, sorry.
Any problem? No problem, doctor. It's as before, it's quite okay.
Okay, okay. Mr. Silva, do you have any drug or regular basis?
No, doctor. No regular medicine I'm taking.
Drug allergy?
Not known, doctor.
Okay. In your family, anyone has similar condition like you?
In family means, doctor? My wife, you mean?
No, I mean your parents.
Oh, parents. No, they don't have any leg pain, doctor.
Okay, okay. Mr. Silva, do you smoke?
Yeah, doctor.
For how long?
Hmm, 30, more than 30 years, doctor.
How many cigarettes per day?
About 10 cigarette, doctor, every day.
Have you ever decided to quit?
No, doctor.
You see, Mr. Silva, smoking is harder for your health. It is better to stop smoking. And at any time you want to quit, I'm here to help you. I can send you to smoking cessation clinic. Okay?
Let me think, doctor.
Okay. Okay. Do you have regular exercise?
No, doctor, no time for regular exercise. Occasionally, doctor, only.
Okay, I will return back to this point. What is your typical daily diet?
Yeah, doctor, I take the mixed food, dif
Mm-hmm.
different types
Okay.
of food, vegetable, meat, fish, everything, doctor.
Okay. Mr. Silva, with whom you are living?
My wife and one son, one daughter.
How things at home?
At home, quite okay, doctor. They are fine, and my wife is very helpful.
Okay, this is good. Okay. Mr. Silva, what do you think the cause of your leg pain?
Doctor, I'm worried. I think there might be some bone damage, doctor, in my leg.
Mm-hmm. And this is worrying you, right?
Yeah, doctor, worrying, definitely, doctor.
Okay. What do you do for living?
I am an marketing person, doctor. I need to
Mm-hmm.
go from market to market to sell the materials on behalf of my company.
Yeah, I understand. This is challenging job, isn't it?
Yeah, doctor, yeah.
Okay. In which way you want me to help you?
Doctor, minimum, I want to get rid of the pain, doctor. And
Okay.
please give me very good painkiller. Moreover, doctor, why it is happening? Definitely,
Mm.
it should be known, doctor.
Okay, I understand. Okay. Mr. Silva, how this condition affect your life?
Yeah, doctor, you see, I cannot walk more as before, and to move in the market, doctor, becoming difficult nowadays. And day by day, it is
Yeah,
becoming more, doctor. My walking distance becoming less than before nowadays in between the
yeah,
pain episode.
yeah, I understand. This must be very difficult for you. I'm here to help you.
Please, doctor, please.
Okay. Mr. Silva, have you ever have this been at rest?
No, doctor, no.
Mm-hmm. Okay. Let me to recap what you told me. You came today because you have leg pain since 2 months and it is worsening with time. You feel this pain when you walk and it is
Yeah,
better when you take rest. You
yeah,
think maybe you have bone problem and you are worried maybe your bone will be damaged
yeah,
and you want
doctor.
me to give you medicine. That is all.
Yeah, doctor, please.
Okay. To know more about your condition, how about examine you?
Yeah, doctor, please. Thank you very much, all of you. Possibly you have heard. Now, the doctor is going to examine. I don't like to criticize the video overall because the how many minutes our doctor took, is it justified or not? This is not the way. Just you have heard the informations after the talk and you just make a gist of the informations and now plan for the examination. I hope Dr. Hind is ready to start the examination. Before that, Dr. Hind, can you tell us what is your plan to examine the patient, please? Dr. Hind, can you open the mic? Hello?
Oh,
Please open again.
hello.
Hello? Dr. Hind, please open the mic. Hello? We cannot hear you. Yes.
Hello.
Yeah, we can hear now. Please. What is your plan, please?
I want to examine general examination pulse.
Pulse. You just
Pulse.
say one by one slowly. Pulse. Then
Yes. Pulse, radial, brachial, and axillary, and in lower limb, bilateral.
eggs and the lower limb, all pulses of the lower limb, you mean? Okay. Then any other thing?
Okay. I want to examine blood pressure.
Okay. Blood pressure was not given in the scenario in the
Okay.
video. Blood pressure given?
No.
in the road somebody measuring.
Yes,
and they
it is
told
not
me at
given. So not given, it's a technically
Not
not
given,
given,
yes.
intentionally not given. That means it is a
Yes.
cardiovascular case you identified, right? From the history.
From the
Dr. Hind,
history, I think.
you
I
understand? You
think
understood that this is a cardiovascular case, peripheral vascular case, you mean?
yes, peripheral
But
vascular case.
leg pain can happen in neurologic case also. Why you are not
Can happen,
thinking this is a neurologic case?
could be.
Would
But
be, but in the history, it is not neurologic case. How you become sure?
yes, this pain relieved by rest.
No, this pain is relieved partially by rest, means after stopping the walking. So it is
Yes.
relieved by rest.
And
So you,
no numbness, no weakness.
weakness. Okay, weakness not there. Numbness
Yes.
means absence of sensation not there, but there is a pain. That means the presence of sensation is there. Any other
Yes.
points? Who can say, please? Dr. Hind will tell examination, no problem. Any other colleague, please can share. Why not this is neurologic case? Yes, Dr. Nida. Can you open the mic? Dr. Nida, please open the mic. Audio. Dr. Hind can continue if anything in your mind. Is there any back pain?
No back pain.
No back pain. So did
Yes.
doctor ask about the back pain? That
No.
means no. So if better, if we could ask, do you have back pain?
The doctor not ask. Yes.
Doctor didn't ask. And if back pain is there, if any moving pain from back to down, it is also can be
Yes.
said as the neurological claudication. Okay.
Yes.
And this is a persistent almost, usually neurological claudication. This claudication is intermittent. Initially, it intermittent. And patient told that patient have the leg wasting a little, right? Becoming thinned. So what, okay,
Yes.
again, we better not to go to the criticism of the performance detail. But in the examination, we are in an opinion that all of us, that it is a vascular case, cardiovascular in the leg pain situations. And in the leg pain, what will be the cause of leg pain in cardiovascular background? It is an arterial problem or venous problem?
Venous problem. Arterial problem.
This is arterial problem you are telling.
Yes.
Other colleague, please, any difference of
Arterial.
opinion, please? Why not this is venous? I'm asking other than Dr. Hind. Please, anyone, open the mic. You can share. But Dr. Hind, be connected. You need to say the examination finding one by one. We are just introducing this case for better understanding. Anyone, please, can tell that this is not venous. Why? In the history. As much as you can be confident on history taking, your examination performance will be better. History is very important. Can anyone say? No one? Dr. Hind, please. Can you answer now? We like to hear the voice. Doctor, better not to write in the chat box. Very difficult to follow there. Feel free to talk over the mic, over the audio. Dr. Hind, please open the mic. Dr. Hind, please. Dr. Hind, we cannot hear you. Sorry, Dr. Hind, please, can you open the mic? Your audio is closed now. Your mic permission not there? Sorry. Unmute. Oh, sad. Now can you try?
Yes, sir.
Yeah,
In
something
venous,
wrong happened there. Yeah, Dr. Hind. Who will tell? Dr. Mohsin? Okay, Dr. Hind, you can wait. Dr. Mohsin, please.
If it is a venous problem, then there will be a stasis or muscle wasting or swelling, and the history will
Doctor,
be
muscle wasting or swelling? You are telling both extreme. If the venous, there will be wasting or swelling. Say only
uh,
one, not two.
swelling will be there.
Swelling will be there. And
And history will be totally different in this
Different means
case.
what different? In
There
favor
will be
of
prolonged pain on prolonged standing,
okay.
or after throughout duty at the evening, when there will be a stasis of obstruction in the venous system now.
Okay. Then
And there will be no such type of pain that at rest it will be relieved, and there will be a pain on.
exactly, it is not like claudication. Intermittent claudication will not be there, and locally it will be a little warm also. Anyway, patient can
Yes.
tell or may not tell about the warmth, and there will be background of what? Drug history or other informations. If it is the deep venous thrombosis, maybe
Traveling.
traveling
time.
one. Second, this patient is not female, right? So unlikely to have OCP consumption history. If the female, there may be background of the OCP consumption also. These are very common thing. Anyway, there are many logics to say this is arterial disease. Now, Dr. Hind started with the pulse, and then what else you like to do, Dr. Hind?
I want to examine your heart palpable for
Heart,
area.
heart.
Yes.
Okay, why
Yes.
heart?
Could be ischemic heart disease or
What you will get in the ischemic heart disease by examination?
no, anything. Could be normal examination.
If it is normal, why we are expecting that I will examine the heart? This peripheral
Okay.
vascular
Examine lower
disease,
limb. Yes.
okay?
Examine
But
lower limb.
no, you jump directly towards the lower limb. From the general examination, you said only pulse, blood pressure,
Temperature.
including the peripheral pulse, temperature of whole body. That means the temperature. That means you are thinking that the leg pain due to cellulitis infection.
Could be.
Patient told nothing there, only pain
But
was sting.
from history, not telling anything.
So if history not telling, we cannot include the examination. So today's discussion really very critical and very meticulous understanding is required to design the focus examination. It's not easy. This is my last experience with the many batches before that. Routinely, we are telling many things in the general examination. We have to have a direct relationship with each sign with the presentation. So patient does not have, patient is not telling fever, patient does not have any history of injury there, right? There is no skin damage. That means the ulcer or other things, swelling. Swelling means not like infected area there, according to the patient's statement. So there is no infection at all. So fever, okay, if you touch the body, then automatically you think that I'm checking the fever. Okay, that means the temperature. And you come down to the heart. Yes, half heart could be justified in another way. Patient have vascular disease. If patient give the ischemic chest pain history, patient have in addition the shortness of breath, then precordium examination will be very important. That is very, very right. But as you think that it is a cardiovascular case, but there is no information, that means no clue in the history to examine the heart, you can skip it. Rather, your lower limb examination is very important. Okay. And heart could be again come into play that you see that the blood pressure is not given there. Pulse is not given there. Okay. If pulse given there, pulse is irregularly irregular. When you are checking the pulse, you found irregularly irregular, or examiner or even the surrogate telling that pulse is irregularly irregular, pulse rate is 120. And the blood pressure is 160 over 100. Then do you think that the examination of the heart will be important?
Yes.
Yes. So this is
Yeah.
the IQ, my beloved colleague, today you need to develop with you. Don't think that only the leg pain, okay, it will be peripheral arterial disease. I got the case. This case is very common to me. But in the station, you need to utilize your general intelligence. Okay, Dr. Hind, come down and examine the leg.
Yes. By inspection,
What you
we'll
will
see,
see?
look, redness, any injury.
Okay.
Any will do palpable to swelling.
Suppose
Then
your diagnosis will be peripheral arterial disease. You tell me your expected finding. In advance, I am telling that it will be a peripheral arterial disease. So because history telling us, this is the forecasting. So examination, what is your expectation?
could be a pulse absent, a pulse.
Okay, pulse absent or reduced volume.
Yeah,
Okay,
or reduce volume.
reduced volume. Where will be your reduced volume? It is the artery dorsalis pedis or the popliteal artery?
The cell species.
Dorsalis pedis. But patient have the problem in the cuff muscle. Do you think that the arterial dorsalis, the popliteal artery will be normal?
Could be
Doctor,
normal.
any other colleague, please respond by opening the mic anytime. You can easily open the mic now, doctor. Your restriction is cleared here. I'm sorry, there are some automatically, the restriction was there. Now it is open. Everybody can open the mic. So if the calf muscle is in problem, ischemic problem happening in the calf muscle. So we expect that popliteal artery will be in problem, even above, though patient does not have the high problem. We don't know where is the level of block there. So arteria dorsalis pedis will be low because the the above one is in problem for that. Is not it?
Okay.
Tibialis anterior posterior, there arteries are there. Okay, one thing. Second, if you feel, what will be the temperature? Warm or
Low
cold?
temperature.
No, asking
Cold.
warm, cold. So you tell one by one. They will be cold. Arterial volume will be low, less volume in the popliteal artery, and then size or the bulk of the muscle will be bulk of the
Decrease.
muscle will be increased or decreased?
Decrease.
Decreased. But patient telling that patient have the pain in the both legs, more in the right. Isn't it? Patient, is it only right leg problem or both leg problem?
One leg problem.
Both leg problem.
More.
If it is so, there may be asymmetry that right leg is in more problem than the left. So in the left also you may get few features or even you may not get also. Okay, and then so you got the diagnosis now that it is a peripheral vascular disease almost. So what will be the complication of the peripheral vascular disease? What else you like to see there in the leg? That means we discussed many times before in even open session that in a case of the OSCE, not OSCE, in our real life also, that we need to diagnose the disease. Then we need to diagnose the etiology of the disease. We need to diagnose the complication of the disease. So in the leg examination, is there any complication of the disease could be there? Dr. Hind, what
Yes,
you
sir.
are thinking?
Obstruction will be provide. Also, there will be a vascular ulceration. We have
Yes, arterial ulceration could be there. So as your OSCE exam is of with the healthy people, we have to say that I am checking now for any ulcer there. It will be the arterial ulcer. So now the question is, where is the location of the arterial ulcer? Who can say?
Middle side.
Medial side? No, doctor, not medial side. Medial side, medial malleolus is the venous ulcer. Lateral
at the
side, the dorsum of the
topmost
leg, dorsum of the leg, or the lower
Close
dorsum of the foot, dorsum of the foot, lower part of the leg. These are the arterial side. So this is a complication. Okay. Any features of etiology there in such patient? Patient, what is the background? Patient is a smoker. Patient have one time high blood sugar record and was not checked later on. Could be there any features of diabetes? Even then, feature of diabetes is not there. Maybe complication of the vascular problem. This is the nervous system involvement. In the severe vascular disease, patient may have problem in the nervous system of the leg as well. Patient may not tell. But in the history also we could ask, do you have any problem of your sensation? That means in the leg. So diagnosis is not enough, remember. If patient tell that I have problem of sensation there, then we need to go for the neurologic examination of the lower limb. But not all, minimum do the sensory examination of the leg. That means history will guide you what will be the examination plan. I am humbly informing you, possibly some doctor could not join today, all of you here, that you can read many books, many PDF articles. You can design your own, but don't rely upon 100% of the book or text, whatever you are reading from. In the examination, we need to utilize our general intelligence for each and every case. The book can give you only simple idea. Don't be packed with the book 100%. Okay, I will see this thing and I become blind. Better not to have such a teacher. Dr. Mohsin, do you like to say?
Sir, should we explain or should we mention the ABI index or not in this case?
Yes, definitely. I'm not, we are still on the discussion. Dr. Hind, please, anything more? We are taking a little more time for the first case. In the next case, I hope that already you understood the technique of practice. So better we will not take more time. Dr. Hind, what that Dr.
Okay.
Mohsin said, what else you will do?
We'll make a leg
AB
circumference.
ABPI, doctor. No, leg circumference is already done to check the bulk of the muscle.
Yes.
The ABPI. ABPI. Yes. What is the importance of ABPI?
Will decrease less than 8.
Less than
Significant.
0.8.
Yes,
Yes,
0.9. It may a little vary in book to book.
0.9 will be considered as severe skin.
Yes, in the GP book it is 8.9.
Yes.
Somewhere at 0.8. Anyway, it will not be a major problem, but ABPI will be less than 1. It is true. Doctor, what is normal ABPI, Dr. Mohsen?
1. It should be 1.
Minimum 1, but usually it is more than 1. What does it mean? It means that ankle pressure is more than the brachial pressure. Physiologically, it is expected it will be more than 1. So whenever it is less than 1 means 0.9 or less, it's considered as there is the arterial tree in the leg is in trouble. Vascular supply is less than physiologic value. Okay. So that is the thing of the leg examination. The major differentiation could be there for your OSCE that it will be DVT or arterial disease. It will be challenging for you in this case, and other thing of the leg pain, other differential could be there. Suppose cellulitis causes leg pain also. Okay. So in the cellulitis, there will be red appearance in the skin, history of fall, background of immunosuppression, many will be there. But apparently, any leg pain, the nearest differential will be 2, peripheral arterial disease and the venous thrombosis. Okay. And then you will read by yourself about the leg pain, the arterial disease management, others. So our intention is actually just to see what could be or to discuss what could be the focused examination, and you will practice like Dr. Hind has done. So I think this chart can be helpful for this. Suppose in any case, the general observation examination, you can make a snapshot also, doctor, of this if you don't have. We just designed for your better understanding. In the observation, for each and every case, we have to scan this thing one by one. But all things are not needed to be seen because all are not relevant. History will guide us. Suppose in this case, thyroid is relevant. What do you think? Dr. Mohsin, thyroid relevant in this case?
No.
Dr. Hind also
Thyroid?
saying no. Yes?
No.
No. But how can we make thyroid relevant? What information will guide us?
If patient with complain of heart racing.
Heart racing, and there may be atrial fibrillation. right? I told you that there may be irregular
Atrial
pulse rate
fibrillation.
is there. So atrial fibrillation, you are examining the heart in the background. There is no cardiac history and your examination. Then atrial fibrillation definitely will go for the heart examination. You are getting nothing in the heart examination. That means thyroid will come forward. Okay, look at the neck. That is relevant, doctor.
Yes.
That the chart, we tried our best to give you almost everything, but you need to focus what sign will be required in such case. Lastly, we are telling the bedside test or side room test. Remember, the side room test means you can do in your chamber. For the actually, I added the word for the GP's background. In the book, it is written bedside test, but side room test. Yeah, Dr. Marwa, we will come to you, please. You just keep your mic open. You can discuss. I'm just finishing this. Dr. Marwa, please. You just keep your hand raising so that I shouldn't forget. The side room means what, Dr. Hind, you will do? It is also actually part of examination, but in the OSCE, they don't recognize it as examination. But it is a bedside test or part of, we say in our clinical medicine, the bedside examination in for the leg pain patient. Suppose the ABPI by the Doppler, it could be a bedside examination, but the machine is costly, may not be available with us. We are sending somewhere else. So what else we need to check in this patient? Maybe blood sugar, capillary blood glucose. Patient given the history of high blood sugar before. So there may be side room test a little. You can say also that I like to check your blood sugar in this case. It may be part of examination also as well. Or you can say it may be part of investigation. Okay, no worry. That's all. Dr. Marwa, please. Sorry, she lost her connection, could be. Anyway, nothing to say. Yes. Thank you, Dr. Hind. If any colleague have any question regarding this case, then we can jump to the next case. Dr. Hind, any query in your mind? What we discussed with you?
Okay.
Nothing.
No.
So inviting other colleague who will be, can you raise your hand to do the next case?
Sir, can I?
Dr. Mohsen, why not, doctor? Thank you. Dr. Hind, okay, be muted. So second case we are giving
Okay.
as before. I think all of you understood how to practice this. Can you read it, doctor, for us? Because font size may be smaller to someone. Dr. Mohsen?
Mr. Kamar Zaman, aged 66 years. Mr. Zaman is suffering from long-standing cough. His BP 130 by 80, pulse 90 beat per minute, and respiratory rate 20 per minute. Proceed with consultation, perform relevant clinical examination, and make a management plan.
Yeah. So you got some prompt here, right? And remember that in coming days in the OSCE exam, such prompt may not be there. You could understand that patient might be having which system disease, Dr. Mohsen?
Respiratory.
Respiratory, maybe. More likely to be respiratory, long-standing cough. But sometime it will be said as Mr. Zaman is waiting to talk to you.
Okay.
Understand, Dr. Mohsen?
Yeah.
And in examination finding, is there any abnormal observation in the examination finding? Pulse, blood pressure, respiratory rate?
Respiratory rate is high than normal.
Yes, higher than normal. Little high, not too much though. So cough and the breathlessness, right? Could be. Though there is no symptom of breathlessness, but little mild breathing difficulties. So in summary, we are heading towards a respiratory case. If it is so, let's move to here, the doctor's performance. Now. Start doctor, minimum give time to surrogate so that surrogate can say you also good morning, good evening. Not like straightforward, suddenly good morning, Mr. Someone, and I am this. Give in between a pause, doctor. Eh? We are not robot. And for you, doctor, you are telling, am I clear, light or something? Just say, is it okay? If you say, am I clear to you, you are taking more seconds, doctor. Sorry, Dr. Mohsen, it is our record. So how many words? It is not an artificial case. There was a discussion between us and the participant. So it is also matter of counting your seconds. These are the techniques. Okay. You are ready?
Yes.
Okay. طيب.
Enter, please.
طيب اركض يا حنان. Okay.
Enter, please.
Hello, Mr. Zaman.
Hello.
Hello.
Hello, doctor.
Okay. I'm Dr. Nashwa. How can I help you today?
Yeah, doctor, I am having cough, doctor, for many days, doctor. I am
Okay.
worried, doctor, why my cough is still persisting, doctor. Please give me very good treatment for my cough, doctor, please.
Okay, I'm here to help you. Can you tell me more?
Yeah, doctor, the cough day by day it is becoming more, doctor, and it is producing some flame also, doctor. And by coughing more and more, doctor, sometime I feel chest pain also, doctor. What you like to know more,
Okay.
doctor?
For how long this cough?
Around 6 months, doctor.
Okay. Is it dry or productive?
Doctor, I told you there is flame.
Which color?
Whitish, doctor.
Whitish. Okay. Any coughing up of blood?
No, doctor.
Okay. Any fever?
No, doctor.
Okay. Any shortness of breathing?
No, doctor.
Okay. During this last 6 months, did you seek medical advice?
No, doctor. I just went to the medicine shop and I took some cough syrup only, doctor.
Okay. Okay. Mr. Zaman, did you notice this cough increase in a particular time of the day?
Not a specific time, doctor.
Okay. Any whistling sound in your chest?
No, doctor. Very, very few. Very rarely, doctor.
Okay. Do you have any long-standing illness?
Other than this, doctor?
Yes.
No, no, doctor.
Okay. Any drug on regular basis?
No, no.
Okay. Any drug allergy?
Not known, doctor.
Okay. In your family, anyone has cough?
My family means my wife doesn't have any cough, doctor.
I mean your parents, your
Oh,
brothers, your
parents,
sisters.
yeah. Yeah, my father was coughing for his elderly maybe as the winter time. Yeah.
Okay. Okay. Any weight loss?
In the meantime, 6 months, doctor, maybe I lost 1 kg around, not more than that.
Okay. Uh, okay. Mr. Zaman, what do you do for living?
I am retired, doctor. I was journalist before.
Okay. With whom you are living?
My wife, doctor, and one son, one daughter.
How things at home?
At home, everything was good, doctor, but for my coughing, everybody is little worried and disturbed, definitely. Always
Yeah.
I'm coughing, abnormal sounds are there, doctor.
Yeah, I understand. Okay. Mr. Zaman, do you smoke?
Yeah, doctor.
For how long?
Many years, doctor.
How many cigarettes per day?
8 to 10 cigarette, doctor.
Have you ever decided to quit?
No, doctor.
You see, Mr. Zaman, smoking is hazard for your health. It is better to stop smoking. And at any time you want to stop smoking, I'm here to help you, okay?
Yeah, doctor. Yeah. If it is the fact, do you think that, doctor, my cough is due to for my smoking?
I will return back to this point. We will see, okay?
Okay, doctor, please.
Okay. What do you think the cause of your cough?
That my question, doctor. Why I'm
Okay.
having this
And
problem?
what is the most worrying you?
Yeah, doctor, is a long-standing cough, doctor. I think I am having many dangerous bug, doctor, maybe in my chest.
We will see. Okay. And in which way you want me to help you today?
Yeah, doctor, I told you, give me some treatment, doctor, so that my cough should be stopped.
Okay. How is this cough impacting your life?
Already I told you, doctor, in my home, they are disturbed, I understand. And
Yeah.
as I'm a journalist, doctor, retired now, I have to go to seminar, symposium, but I cannot go for my coughing doctor there.
Yeah, I understand. This must be very difficult for you.
Yeah, doctor, yeah.
Okay, Mr. Zaman, you came today because you have cough for 6 months and it is producing white flame. You think maybe you have bug and you want me to give you medicine. That is all.
Yeah, doctor, yeah.
Okay, to know more about your condition, how about examine you?
Please, doctor, no problem, please.
I would like to check your general physical.
So I stopped here. Dr. Mohsin, please, can you open the mic?
Yes, sir.
Yeah, so what in the history, what you gaze that what could be possible diagnosis? This is very critical and very important.
Sir, he has excluded all the possible causes like tuberculosis, carcinoma malignancy, or COPD, cardiovascular. Which has just remained is an allergic cause. Maybe it's an allergic cough. She didn't have asked about any allergy.
Allergic to any
There is
dust
no
and other, you
fever.
mean? Okay.
Maybe, sir.
Okay. Be stopped
Because
there, Dr.
there's
Mohsin.
no other.
Let's hear from other colleague. I think some of you already opened the mic. Dr. Iram, please. What you are thinking? Dr. Mohsin, you will come later, no problem. You will tell the examination finding this as you responded. Dr. Iram, your mic was on for that I'm asking. Dr. Hind, what you are thinking?
Could be idiopathic lung fibrosis.
Fibrosis producing flame, doctor? Productive cough? Please, everybody can share in the discussion. Is there any relevance of smoking many years? Productive cough, smoking? Dr. Haram?
Doctor, can it be gastroesophageal reflux?
No. I am thinking that you just being away from the respiratory disease. But patient have the background of long-standing smoking, productive cough. How can we come out from the lung, doctor?
Bronchiectasis.
Bronchiectasis, yes, could be a possibility of bronchiectasis in the COPD patient. There may be complication later on by bronchiectasis, but other than COPD also separately, it may be bronchiectasis with a background respiratory illness in the childhood or previous life. Okay, it could be. If it is so, Dr. Hind telling anything more? Please, who open the mic? You can share, doctor.
I think COPD.
You are thinking COPD. Yeah, Dr. Haram, do you agree with this COPD?
Yeah.
I think yes, it is going with COPD because this long history of cigarette smokers.
Okay. That other thing could be differentials. If you think this is COPD, other thing. Suppose an allied differential, usually we think of bronchial asthma. Everywhere. The long-standing breathing problem, common disease, if allergic background is there. But someone said allergy, Dr. Who said? I forgot. Can you open the mic just to interact with you? Allergy history, Dr. Mohsin said maybe. Yes.
Yes, doctor.
So if it's allergic, suppose asthma usually does not present in the later age, very uncommon that patient have. And the coughing, breathlessness is persisting, increasing, not like that. Asthma is a disease of up and down. So progression of the symptom, we discuss in our basic classes, OPD cats. OPD cats. There are minimum 7 features of any symptom. From there, you could understand that it is not asthma. It is a persistent progressive disease, productive cough in a smoker. Commonly, we should think COPD. COPD. Other thing differential. Someone said it is bronchiectasis. Dr. Mohsin, can you say it is unlikely to be bronchiectasis in the history? Why?
In bronchiectasis, there may be a lot of phlegm up to full of cup per day, or there may be a morning. There will be a history of when I raised in the morning. There will be there is more phlegm expectoration.
Yes, phlegm, doctor, phlegm. Phlegm. That means a
Color
sputum.
of phlegm. Yes.
The color may be if there is infection. Okay, color will not very significant. If blood is there, it is significant. And now, if you think it could be COPD, a little we are thinking it could be bronchiectasis, keeping in the mind, or even very less possibility of bronchial asthma, though late, it is called late onset bronchial asthma. Patient also telling that there little occasional wheeze also there. So asthma aggravate in the dust area, in the cold, as well as COPD also will have the same. So keeping 3-4 differential, somebody said this is interstitial lung disease. Less likely because interstitial lung disease will not produce productive cough. Usually it produces dry cough. Anyway, maybe we could think no problem, 3-4 diseases of chronic lung disease here. Now, the examination plan. Dr. Mohsin, it is your session now.
Yes, sir.
What
Firstly,
examination, before going there, you tell me what is your intention in examination? Definitely to diagnose the case. Then?
to exclude cyanosis.
No, I am asking. The principles of examination will be to diagnose the case. Second, to exclude the differential diagnosis. Third, to identify complication of the disease. Right? Minimum, this is very vital, complication of the disease. And is there any apparent etiology? If needed, if possible, I will examine to exclude or to detect any etiology. If usually etiology will be apparent, would be apparent in the history. Do you have such thing, such thing? So 3-4 things. In addition, also, suppose in the history, do you have diabetes, high blood pressure? That means the comorbidities. And any case presented to you to identify it is an emergency situation or not. So with these things in the mind, we have to proceed for the examination. Now, Dr. Mohsin, tell what general examination you will do.
I will perform examination for peripheral cyanosis, clubbing, capillary refilling for on fingers. No, then I will do examination of the mouth cavity for central cyanosis, and then no need of GAVP in this case. No. Yes.
No need of JVP. Why you are thinking no need?
Because BP and pulse are normal.
BP pulse could be normal in the congestive cardiac failure. Suppose I'm telling, but here patient of the lung disease, could patient have right heart failure?
He has not given the history in case of sinus breathlessness, signs of
Doctor,
breathlessness.
is the breathlessness features of right heart failure or left heart failure?
Left heart failure.
But this patient may have right heart failure if it is a cor pulmonale. So this is also complication of the disease, right?
Okay.
So now you are thinking straightforward JBP not needed. Okay. Hope we will correct ourselves. Yes, JPP could be important. Before that, in the examination, we will get some findings in the chest also as well, even in the precordium. Anyway, JPP may be related, may not be related. It is true, but in the part of the general examination, we need to include JPP. Okay,
then we will do inspect for peripheral edema, ankle edema.
Yes, ankle edema. Then?
And this?
In the hand, doctor, what you have checked in the hand?
Clubbing, cyanosis.
Clubbing. So how clubbing is important in this case?
He has a long history of smoking.
So how clubbing related with his smoking? Who can say, other colleague, quickly join. I think some of you must know it. How clubbing is there in this case. Dr. Mohsin, please be connected. Why you become off? You will continue. Okay. We are inviting other just to add something here. Clubbing is a feature of bronchiectasis. As we are thinking, it is bronchiectasis or not, clubbing can give idea. Again, interstitial lung disease, clubbing will be there. Again, cigarette smoker, patient might developing cancer of the lung, patient may have clubbing. Clear now? But only COPD, patient will not have clubbing. It is unlikely to have clubbing. If it is complicated COPD, complicated by malignancy, then patient may have clubbing. So clubbing is must here and important. Second thing, in the eye, doctor, anemia is important in this case.
No, maybe a polycythemia. There will be a polycythemia in COPD.
Polycythemia. So we have to say that I am checking the eyes for polycythemia. Anemia in a cigarette smoker may be important, doctor. How? How? Dr. Hind, do you like to say? You open the mic. Again, cigarette smoker might develop lung cancer, doctor. So cancer patient will be anemic.
Because anyway.
Yes. So we need to expand our horizon of understanding, doctor. In this way, in the group discussion, doctor, I think all of you understood. Oh, right. Yes, it could be seen. But if you don't interact with each other, it will not come. So OSCE preparation will be like that, doctor. Will be group discussion, interaction, and sharing informations, interacting. It is the principle of that. Anyway, in the general examination, then we will go to where, Dr. Mohsin?
Capillary refill. I will check.
Capillary refill is the features of a peripheral circulatory failure. This
Okay.
patient blood pressure is very nice. So
Okay.
it is not important. It is not important. In the precordium, if you want that, there may be cardiomegaly due to right heart enlargement, right ventricular enlargement. Even you can add that hepatomegaly if patient complain tender feeling in the abdomen. So many things could be there, but in the OSCE again, doctor, we will have less time. Already in the history, sometime our colleague is expanding. How many? 6, 7, 8 minutes. You are given only 10-minute time. So many examination you may not do. That I am always alerting you that when you see the books, notes and others, you can find a lot of signs, but all signs are not needed to be explored. For diagnostic purpose, 2, 3, 4 signs enough. For complication, maybe 2 signs like that. For and to make our hand speedy, we have to practice. So in the lungs, doctor, what you expect? Suppose I am now telling you are confident near about that it is a case of COPD. In the chest finding, what you are getting?
There may be wheezes or vesicular bronchial breathing.
You are telling or. That means you get this one or this one, not both.
Wheezes. I can get wheezes or cramps due to pulmonary edema.
Wheezes or, not both again. Doctor, tell in English, not Hindi or Urdu or, doctor. Or means and, right? But in English, it is an alternative one. So say in English, not in Hindi or Urdu, doctor.
I will check for any wheeze.
Yes.
Added sound.
Yes.
Added sounds.
So what? So before telling the added sign, what we have to say? Breath sound first. Isn't it?
Yeah.
So if I suddenly rush to there in the exam hall, okay, I will see the wheeze or the or crepitation or and crepitation, but I am skipping what is very common. This is the breath sound. It may be normal or abnormal. So this is the way of examination, doctor. For that, it needs again practice that even in the virtual session we do it. Then I will check breath sound, then go for the added sound. For example, the wheeze or crepitation. You can say in this manner. Don't jump the method, okay? Usually in healthy people also we listen the breath sound. So we couldn't, and there may be expected finding also in the breath sound. What is that? Vesicular breath sound with prolonged expiration. Isn't it? Vesicular breath sound with prolonged expiration, and I am checking for the wheeze. Surrogate will tell you, usually wheeze may be scattered, not in the both lung fields extensive. Some wheeze will be there. There may be little crepitation. In any infective episode happen, there may be more crepitation. Okay.
Okay.
So a lot of discussion could be there, but up to this for this one. Now, In the history and others, when you face a COPD, a lot of things actually you have to discuss, but time may be short. So you need to practice more and more in a COPD patient, and diagnosis will be easier, doctor. From the history, it will be easier. Okay. Then in the management part, you will do by yourself, doctor, detail of that. So again, this is that visual impression for you to design in your examination planning. You may create your own one, doctor, suitable, most suitable for you, but this is our presentation from the DOAMS. We tell it clinical examination planner. In real life, we are practicing it. So from there, what you will do, you will understand. And the sacral edema could be there, doctor, right? Mohsin is important in this case, sacral edema.
Sir, if he is a bedridden patient, then we will then check
Yes, sacral edema. But in the OSCE, usually patient will not be in the bed. Usually patient will be in the on the chair. Okay. And bed is there. You can approach. Okay, can you lie down on the bed? Because respiratory examination needs patient should be propped up to 45 degree. Isn't that it? Dr. Mohsen, why become off, doctor? Sorry, yeah. Keep connected. 45 degree, right? 45 degree. But if remember, if in the exam that there is no arrangement of bed, you can examine the patient on sitting on the chair. No problem.
Okay.
But remember, bed there means you have to request the patient, can you lie on the bed? Okay. So any question, my beloved colleagues, regarding this? Actually, we are interacting each other to make our sense of focused examination. As we discussed before, discussion only happened. So we were thinking that come to a session, suddenly actually we created our mind.
Excuse me, sir. In this case, we only just perform auscultation, not palpation, expansion of chest or.
All are not important, doctor. In the history,
Okay.
you are near about the diagnosis, right? Expansion, okay. But again, look at the time, doctor. Look at the time. There may be inspection, palpation, percussion, auscultation. Time will tell you how much you will do. If you have enough time, you can do little from inspection, percussion. Percussion actually will give nothing here, almost, if you see COPD. Maybe hyperresonant and other bilateral. So it will not give any lateralizing features. You can skip it because the diagnosis of COPD rely upon auscultation. Okay.
Okay.
If percussion is there, there may be lower down of the liver dullness, upper border of the liver dullness in the right side interiorly. But we advise and we practice also to check the chest from the back mainly. If COPD, it is enough. If you don't go for the liver dullness down, it is not bad also. Your diagnosis will be clear from the history as well as this bilateral scattered rhonchi. And initially that the vesicular breath sound with prolonged expiration. So vesicular breath sound prolonged expiration caused by two common diseases, COPD and the asthma. In the history, it is not asthma. Okay, and the rhonchi are not polyphonic bilateral rhonchi. So only the diagnosis will be COPD. So auscultation is mandatory. If you have time, you can add other steps of examination, doctor. Okay?
Okay.
Don't worry. So we are at the last case now for you. Enter, please.
Good evening, Mr. Khan.
Good evening.
I'm Dr. Nashwa. How can I help you today?
Yeah, doctor, I'm having fever, doctor, last 7 days. It is not going down, doctor. Every day it is coming and going, but not being finished, doctor. And I am having moreover malaise, doctor, also. I am not feeling well. Doctor, what is wrong with me, doctor? Please check me, doctor.
I'm really sorry for this fever you have, Mr. Khan. Can you tell me more?
Doctor, what you like to know? Actually, last 7 days, doctor, it just started and it has some shivering, doctor, when it comes up. And later on, doctor, it subsides with sweating also, doctor.
Yeah, I understand. Okay, Mr. Khan, do you have any headache?
Yeah, doctor, when I have fever at that time, doctor, especially I have headache.
Okay. Any neck pain?
No special neck pain, but whole body is in pain, doctor.
Okay. And do you have any tummy pain?
No tummy pain, doctor.
Okay. Any joint pain?
No.
Okay. Do you feel sick?
Yeah, doctor, I feel sick.
Do you throw up?
I didn't throw up.
Okay. Mr. Khan, do you have any recent travel?
Reason, yeah, doctor, just 7 days before actually I returned, doctor.
From where?
Sudan, doctor. I went Sudan.
Okay. How many days you spent there?
2 weeks, doctor.
2 weeks. Okay. Before you went to Sudan, did you took any prevention for malaria?
No, doctor.
Okay. Okay. Mr. Khan, with whom you went Sudan?
With my business partners, doctor.
Okay. May I ask you a personal question? Private question?
Is it important, doctor?
Yes. There is
Okay,
any
doctor, okay.
okay, any unprotected sex?
No, doctor.
Okay, okay. Mr. Khan, do you have any drug on regular basis?
No, doctor.
Drug allergy?
Not known.
Okay, okay. In your family, anyone has similar condition like you?
No, no, doctor. They're quite okay.
Okay. Okay. You told me that you are businessman, right?
Yeah, yeah.
With whom you are living?
Yeah, here, doctor, my wife, one son, one daughter.
Okay. How things at home?
They're fine, doctor. My wife, much cooperative, doctor.
Okay. Do you smoke?
No, doctor.
Well, what about alcohol?
Occasionally, doctor, not regular.
Okay. In Sudan, you eat from outside?
Not always outside, doctor. Sometime in the hotel and sometime outside, and sometime I eat some street food also, doctor. Because these foods are very tasty, doctor. There, people are eating, and
Okay.
I also ate.
Okay. Any mosquitoes there?
I cannot remember, doctor.
Okay.
But
Okay.
I need to go anywhere out in the outskirts also, doctor, for my business purpose to go here and there.
Okay. Okay. Mr. Khan, what do you think the cause of your fever?
I am afraid, doctor. After returning, suddenly I got the fever, doctor.
You are afraid from what?
Any dangerous bug, doctor?
Yeah, I understand your worries. And in which way you want me to help you today?
Yeah, doctor, check me, doctor. What is wrong with me? And if it is a bug, doctor, give me very strong antibiotic, doctor.
I'm here to help you. Okay. How is this fever affecting your life?
Yeah, doctor, I have to attend very important business meeting, doctor, after my return, but I couldn't go to my office, doctor.
Yeah, I understand. This must be very difficult for you. I'm here to help you.
Yeah, yeah,
Okay.
doctor, please, please, doctor.
Okay. Mr. Khan, you came today because you have fever and this fever since 7 days. You returned back from Sudan you returned back 7 days also from Sudan, and you think maybe you have dangerous bug, and you want me to tell you what is
Yeah,
wrong with you. That is
yeah,
all.
yeah, 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 doctor,
Okay.
please, please.
By the way, do you have any skin rash?
No, doctor.
Okay. Any eye pain?
No.
Okay. Mr. Khan, to know more about your condition, how about examine you?
Yeah, yeah, please, please, doctor. So that's all. Now we need to examine the patient. Who wants to examine? Dr. Hind is ready. Even then, still, doctor, any other colleague you can raise. You can raise the hand. We can share with you also. Anyone, if you want, you can raise the hand. Dr. Hind, please proceed. What in examination plan in your mind?
Examine vital sign.
Tell
Yeah,
me
present.
one by one, doctor, and why. Better you can explain also for a better understanding by all of us.
temperature,
Definitely, we will
temperature,
start from the general examination. So,
yes.
pulse, blood pressure, you mean? Respiratory
Pulse, blood
rate.
pressure, temperature,
Already
respiratory
given,
rate.
doctor. Already given, so no need to repeat. Blood pressure given, pulse given, temperature given.
Pulse, yes.
So no need to repeat. What else?
I want to examine eye.
I for
What
what?
this?
Actually, from the history, you tell your probable diagnosis. Did you get any clue there?
Could be malaria.
Why you are thinking?
Could be thinking malaria.
Why? Why? What is the clue?
Fever. Came from Sudan.
Okay.
Not give
Prophylaxis means
prophylaxis from malaria.
okay. Okay, then you think that all people returning from Sudan, everybody febrile,
Then
every
high
febrile
temperature.
patient will have malaria. High temperature is there, but it's up and
No.
down. Intermittent fever. It can give an idea, intermittent fever. Okay. So we have to say specific clues that it could be malaria returned from the Sudan. Sudan is endemic. Most of the areas endemic, right, Dr. Hind, for the malaria?
Yes.
So that there
Could be enteric fever.
could be there enteric fever, patient moving there for the food, right? Street food.
Yes.
He told
Right,
that
for food.
he was enjoying street food. It was very tasty. Maybe food related infectious disease.
Yes.
So such travel history is important in this case, though we are not discussing there. So we are thinking it could be enteric fever, it could be malaria. But what is the duration of the fever? 7 days. 7 days, right? So it could be enteric fever
2
also.
weeks. 7 days.
7 days. Returning from Sudan, patient suffer from
Yes.
7 days fever, up and down, intermittent fever. He's a businessman. What other possibilities could be there? It could be STD, right? For that, the doctor asked about the personal history also with whom he visited there, right?
Yes.
So many things are there. Anyway, if it is travel disease, doctor, remember the tropical disease or especially the malaria. The enteric fever is almost endemic throughout the South Asian countries. Most of you, as you are planning to appear in the South Asian OSCE, enteric fever is endemic. And in South Asian countries, whole country is not endemic. In the African countries, Sudan almost so far we understand, Dr. Hind and other colleagues can tell, most of the area may be endemic for the malaria.
Yes.
In Pakistan, Bangladesh, India, not whole country endemic. There are some hilly areas. Only those areas are endemic for the malaria. So we have to ask also that did you visit any hilly area, forest area also? And a specific question was nice that what about the mosquito? Is there any bite? Anyway, so more likely it could be malaria now. But enteric fever could be a differential now, or even other infectious disease, whatever, a febrile patient. So we have to proceed with the examination plan for an acute febrile illness. Now, Dr. Hind, say one by one. You already said that this is vital signs already given. Next.
And I want to examine eye.
You tell the name of the sign, doctor.
For jaundice.
Jaundice, okay.
Jaundice.
Other colleague will comment, please, if Dr. Hind has done or told, Dr. Hind told something wrong or you can't understand, please raise the hand or open the mic. You can share later on. Let Dr. Hind finish first her examination plan. So jaundice, then one by one, tell one by one.
After that, we'll examine lymph node.
Okay.
And examine your tummy.
Tummy, for what? You say the name of the sign, doctor. Tummy for what?
Splenomegaly.
Splenomegaly.
Yes.
Only splenomegaly.
Mild increase hepatomegaly.
Okay, maybe mild or the bigger one. So splenomegaly as well as hepatomegaly.
Yes.
I think your colleague today all are agreed upon with your plan.
If anyone doesn't agree, you can share, doctor. Don't allow us to go in the wrong way. Okay, next. No other thing.
No, خلاص.
Khalas. Khalas, I think all of us today understood the word khalas. No problem. Any other thing, doctor? Other colleague can join with us to say additional thing in this febrile patient. Dr. Haram, please.
Doc, she said eyes for jaundice only.
Okay.
Yeah, she said eyes, examination of eyes for jaundice, but she can check also for color. Maybe malaria can cause
Malaria,
anemia also.
yeah, very right. Malaria can cause hemolysis.
Okay.
So maybe there may be initiation of the anemia, right? So wherever the jaundice, there may be anemia also because malaria causes hemolytic jaundice, right? So anemia is important.
Yes.
Good, Dr. Haram. So likely, Dr. Haram, any other one? Please add any more. So you get the findings in favor of malaria, hepatosplenomegaly, just maybe not too much bigger, small organomegaly there. Doctor, someone open the mic. I missed it. Can add, please? Open, be open, please. So nothing else.
Sir, should we check the neck rigidity? Because in
Yes,
malaria,
that I was expecting to tell. Yes, it may not be malaria, it may be meningitis. Okay, usual meningitis will be unconsciousness there, but is adult patient may not have full unconscious. So in a acute febrile illness, neck rigidity important as a part of examination because it may indicate very severe situation also. So other than anemia, jaundice, lymphadenopathy, febrile patient, in the traveler's background, right? Even in a traveler background, okay, think it is not malaria, maybe other disease. That can cause lymphadenopathy as well. In immunosuppressed patient also, lymphadenopathy important. Infectious mononucleosis. If you see this, Mr. Khan is a businessman. If any clue of sexually transmitted disease in the history, so many things could be there. In the history also, we can come back. Do you have any research from a private part? Many things in the history. So we are not discussing the history detail, only examination. So the signs relevant with positive finding in a febrile patient, you must include. So in the general examination, you said, abdomen, you said, definitely. In the traveler's point of view, usually traveler's fever means it may be malaria, it may be enteric fever mainly. Third may be STD for HIV or other sexually transmitted disease. These three groups of disease or headlines are important for traveler's infectious disease.
But should we check over oral cavity for a tongue?
Yes, yes, doctor. Yes. Immunosuppression means there may be fungal infection, sore throat, redness. Patient may not tell, but we have to say. As a part of the general examination, we need to open the mouth. Can you open the mouth and see? Yes, oral condition is important. Any other addition, doctor, by anyone?
Signs of dehydration
Yes, fever, signs of dehydration, definitely. Fever patient is very right, very right. And even not the sign, in the history of dehydration also. History of dehydration means asking about the urine output. Right? Asking about the urine output. And you can ask also that, are you feeling thirsty more as a symptom of dehydration? But asking about the urine output is important in the history, as you are thinking to exclude in the examination. Okay. But again, some technical point of view. At the last minutes, we are discussing that, for example, we are thinking dehydration. So we may get the clue from the history, we may get the clue from the examination. In this situation, we have to think which observation will be a stronger evidence, the examination finding or the history. If we can identify that examination finding is important, stronger, so we can skip in the history. I think you understood, Dr. Mohsen, you are connected and Hind also there. Do you understand, Dr. Mohsen? As you are voluntarily open the mic, so you will get the maximum benefit, no problem. Suppose anemia in the examination. So there is no history finding directly tell that this is anemia, though there may be fatigability and other. Many causes of fatigabilities are there. But examination, that means the pallor in the conjunctiva, is a very important sign for anemia. So I will not ask the patient about anemia or something. There is nothing also to ask about anemia directly. But in the examination, anemia to be seen by self. So I can keep the examination of the conjunctiva to see the anemia, not in the history. It is also important. But you don't think that I'm telling messages that the history can tell something, examination can give some idea. But in many situations, we shouldn't repeat or we shouldn't duplicate the same findings, same observation. Otherwise, we cannot manage our time. Similarly, neck rigidity. Suppose we can ask in the history, neck rigidity. Do you have any tightness or stiffness or bending of your neck? But more finding will be examination in the neck rigidity to exclude the meningitis, right? There may be Brzezinski sign and others. But neck rigidity could be an screening one to exclude meningitis. So in the examination, we can include neck rigidity in our examination. Any other thing, doctor, to discuss? No more. Thank you very much. Thank you.
Thank you.
Thank you, sir.
Okay,
Thank you.
doctor.
Thank you very much, Doc.
Bye-bye.